I'm Dr. Landon Trost, the director of the Male Fertility and Peyronie Clinic in Orem, Utah. Now, this specific video is designed to give you updated information on recommended treatments for Peyronie's disease. We'll periodically update the slides within the presentation to keep this as accurate and up-to-date as possible. Also, we'll be doing individual videos on specific treatments so we can go into greater detail. So you may wish to check our YouTube channel for those at some point. Now, getting into this specific presentation, by way of disclosure, I'm the inventor of a specific penile traction device known as Restorex. This was something that I invented at Mayo Clinic after we looked at our data on the efficacy of other traction devices, and we'll talk a little bit about it in the presentation today. Mayo basically has a place where you can email them with recommended inventions. They take it away from there. Regarding my specific conflict, Mayo gave me two options. One, I could invest in the company developing the product, or two, I could do research on the device, but I couldn't do both. I chose to do research, but that said, I'm still going to be a little biased as the inventor of the device. So take anything I say in that regard with a grain of salt. Now, getting into the presentation, first things first. Probably one of the most important things to look at is which symptom bothers you the most with Peyronie's disease. Is it the curvature? Is it the ability to penetrate? Is it length? Is it pain? Or is it something like hourglass, indentation, or other penile deformities? When you look at treatments overall, there really is no one-size-fits-all treatment. Depending on what bothers you the most will really determine which therapy makes the most sense for you. When you look at men in general who present to a urologist for symptoms of Peyronie's disease, the majority come in with complaints of penile curvature. You can see in this slide that penile curvature is roughly 80 to 91% of men were complaining of that, whereas nodules, pain, erectile dysfunction, penile shortening, those were much lesser numbers. You're looking anywhere from, say, 10 to 30% of men will have those symptoms. Also, surprisingly, only about 10% of men ever recall penile trauma, so don't be surprised if in your case you just noted onset of curvature without any preceding events for it. So in general, as far as treatments, men in the early phase of disease, or what we call the acute phase, which is particularly the first 3 months and really especially the first month, you want to begin treatment immediately. You don't want to hold off on treatment at all. And that's contrast with what many physicians will tell the patients, where they say, oh, wait on it a year, you can't do anything until a year. That is not true. It's something that we definitely want to get across, that those types of treatments you want to do immediately. Now, in contrast, those who have stable disease, so no pain, no change in curvature or the plaque or scar, no change in deformity, in those men, there's no real specific urgency to treatment. This is not cancer, for example, where you need to treat immediately. The urgency in these cases really depends on how much it bothers you. If it bothers you a lot, you come in and get treated. If it doesn't bother you, then you can hold off. Because really the outcomes are going to be similar whether you treat it today or you wait 6 months and treat it in that case. So getting into treatments, the caveat here is I'm only really going to describe treatments that have consistent evidence for benefits. There are hundreds of treatments which have been described for Peyronie's disease, so we're only going to discuss the best options. We'll be doing individual videos that will go into unique individual type therapies, but again, these are the best ones with the most evidence available. The treatments that we're going to talk about are going to be based on 4 different goals of therapy, whether that's curvature, length improvement, pain, hourglass, or other deformity, and we're going to go in reverse order here. So talking first about hourglass or other deformity, this occurs when scarring impacts either the cross fibers of the penis, the middle septum, or what's called the circumferential fibers of the tunica. These are very difficult cases to treat in general. There's not really any great conservative therapies that you can do. We have some data from one of our randomized trials that traction with Restorex may improve hourglass to some degree, but really there's not a great conservative option out there. Surgery can address this. Placement of a penile prosthesis, for example, can balloon this area out. If you need incision and grafting, that can also help address this symptom. And you can even put a graft around the area, so a surgical graft, without cutting into the curvature at all to help buttress this or to create additional support. But hourglass is a really tricky condition overall to treat. So moving on to penile pain. Pain means that there's ongoing inflammation or disease with the penis. Now, this will likely resolve on its own without treatment, but sometimes it takes many years until it fully resolves. There are many people who recommend therapies such as NSAIDs or something like ibuprofen to improve the treatment, but really you can just take that prior to intercourse or sometime when you need the erection. There's very few well-done studies with placebo controls to determine if any therapies improve pain more rapidly. We do know that therapies like Xiaflex, traction, and vacuums do not relieve pain. We also know that interferon is likely the best at pain improvement, and we'll talk about that data in a second. But oral pills is where the big unknown is. We don't know if these really do help facilitate pain improvement or not. So interferon, this is the largest high-quality study done on intralesional interferon. It was led by Dr. Wayne Hellstrom out at Tulane. In this series, it was multiple different sites that compared interferon to placebo, and they showed that roughly 2/3 of men who were treated with interferon had pain improvement during the study period, compared to placebo, where only about 1/3 of men experienced improvements. Now the treatment here is basically 12 injections, where you perform an injection every other week during that time. So moving to the third one here, penile length. So penile traction therapy is really the only non-surgical option that's available to improve penile length. But the mechanism for this isn't well known. We don't know if it's stretching good tissue, if it's remodeling the scar tissue, is it all the above? There's just not enough data out there known as to how or why this improves things. Also, it's important to know there's really 2 generations of devices out there. The first generation of device uses this long rod on either side that can be slightly expanded. Andropenis has the most studies out there. Pennymaster has 1 clinical study. But the thing about these first generation devices is they require about 3 to 9 hours of use, and the data is inconsistent. About half the studies show improvements, half don't, so it's a little more of a wash of data. Well, because of that, you can see this was a study we did back at Mayo early on when we were using those first generation devices. And this picture on the right, basically every black dot is an individual patient, and you can see how many hours of traction that particular patient did. So the ones on the 0 line are men who didn't use traction during Xiaflex, whereas the other ones are men who did use traction. And you can see that even those who did over 700 hours of traction therapy had no greater improvement during Xiaflex compared to those who didn't use it. This is what ultimately led us to develop a new traction device that was later licensed to a company and sold as Restorex. So there are 3 main differences with Restorex compared to other traction devices. The first is the clamp design itself. This allows for a spreading out of the force on the whole head of the penis rather than just a small area where a rubber band type thing goes around. The second thing is it allows for counter traction. And the third is that it allows you to dynamically adjust tension that's placed on the penis. So this video highlights specifically the dynamic adjustment that occurs with the device. You can see the clamp going down here and then the device being extended until the penis is fully stretched. A spring is then engaged, and you can see that it keeps you within a treatment zone. But when the penis stretches too much, where this white line appears and you're outside of that treatment zone, the device can then be dynamically adjusted, which is unique for this device compared to any of the other ones. And I think this is probably the reason why we see results much more rapidly with this device compared to other ones. So once the device was developed, we did a follow-up study at Mayo where we looked at men who were treated with Xiaflex plus Restorex versus Xiaflex alone versus men who were treated with Xiaflex plus any other traction device such as Andropenis, X4, Pennymaster, any of these things. And you can see here when we're looking at penile curvature that the improvements in curvature were nearly double when you used Restorex and Xiaflex compared to Xiaflex alone or Xiaflex and any other traction device. Similarly with length, you can see that when you combined Restorex and collagenase or Xiaflex, you got a greater improvement compared to any other traction device or Xiaflex alone. Well, this other slide here shows results from that same study where you can see that you had nearly a doubling of outcomes with Restorex compared to Xiaflex alone. And we did 3 additional randomized controlled trials, and all of them showed improvements in curvature, where we analyzed that, improvements in length, anywhere from 2 to 2.3 centimeters. So moving on to the final discussion point, curvature. What are different treatments that are available for penile curvature? The very first decision point here is, how good are the erections overall? If you get good erections with either pills, so like Viagra, Levitra, Cialis, Stendra, or injections, then we'll move down the left side of the pathway there, which talks about the treatments for penile curvature. If you don't, though, either you don't get good erections with pills, or you don't like injections for any reason, then typically we place a penile prosthesis, which will address the curvature as well as the erectile dysfunction. So moving down the left side, when you look at first-line options to improve curvature, one option is just to do nothing and just observe it. There was a good study by Mulhall and colleagues that looked at men who were seen in the clinic, did nothing, and then were seen later, anywhere from 6-12 months or so later. In that study, about 15% of men improved overall, about 45% of men got worse, and about 40% of men stayed the same. The second option here is to perform traction with Restorex, and we'll get into this data in a second. The third is to do a combination therapy of Xiaflex, traction, and sildenafil. And then as an alternative that we'll discuss briefly, intralesional interferon remains an alternative option. And really I use this most for men who don't qualify for Xiaflex or who failed to get an adequate benefit with Xiaflex and who don't want to do surgery. So looking first at traction with Restorex, we did a randomized controlled trial at Mayo Clinic in 2019. And that showed that roughly 3/4 of men who were treated over a period of 3 months experienced an average of 30% curve improvement. About 50% of men had a greater than 20% curve improvement overall. And you can see the figure on the right. This is a waterfall plot that shows each individual participant and where they ended up falling as far as their improvement in degree of curvature. Well, moving on to Xiaflex, traction with Restorex, and sildenafil. Again, you can see the same figure we showed earlier, that when you combine Xiaflex and Restorex, you get roughly a twofold greater improvement compared to those who do Xiaflex alone. And again, this was a study that we published in 2019. Well, the sildenafil component here comes from a study in 2018 out of Italy. This group, it was a well-done study, treated with Xiaflex alone or Xiaflex plus sildenafil, and showed that those who had the combined treatment had about a 26-degree improvement versus only 17 degrees in the Xiaflex only arm. Now my take home here is that probably the sildenafil or Viagra caused more firm erections, which then helped act as kind of internal traction to basically straighten out the penis a bit more. But the way I really look at it is there's likely no harms to doing this, so you might as well combine the therapy as well. So moving on to alternative options. When you look at interferon, now we haven't published this data yet, but we looked at a series of several hundred interferon patients and several hundred Xiaflex patients and tried to see who did better overall. And you can see the interferon is in red, whereas Xiaflex is in blue. And basically, the take home here is that interferon did about 2/3 as well as Xiaflex. So it's maybe not as good an option, but it's also not a terrible backup option, or an option that you can use as a second line type of treatment here. Well, why do we consider all these previous therapies as first line? And really it comes down to this risk to benefit ratio. There's no real long-term or not a high risk of long-term side effects with any of these prior therapies. Also, unlike surgery, you're not really burning any bridges. Once you do surgery, you can't undo surgery. But the other factor here is, based on a study we published a little while back, Xiaflex improves many key outcomes, such as the ability to restore penetration or to prevent surgery, and hence it makes a very good first-line option. So when we look at second-line options, you can see that there's a couple different surgical options available here, and we'll talk about each one in a little more detail. Penile plication is one type of surgery where you basically put stitches in the opposite area of the point of curvature. Now the good thing about this is it'll get you straight immediately, but the bad thing here is that there are a couple side effects which you may notice. The most noticeable one is typically loss of penile size. So now your stretch length will still remain the same. Whether you stretch it before and after surgery, it'll be the same, but your perception of length will be that it has shrunk. And the reason for that is that the volume of the penis is less. You're basically pulling in your long side to be equivalent to your short side. Also, you can get a modest recurrence of curvature over time, in particular 3 to 5 years out, and you can always feel the knots. The sutures are permanent, so you feel these little bumps in there. This particular surgery is typically reserved for men who have curvatures of 60 to 70 degrees or less. Incision and grafting is another type of surgery. This is a much more aggressive surgery. We usually use this for cases of severe curvature or curvature plus severe hourglass deformity. Again, like plication, the good is you'll get straight immediately, but the downside here is you will get worsened erections. You may not get erectile dysfunction, but you will get worsened erections, guaranteed. You'll also potentially get changes in sensation, and these may be temporary or long-term. You can still get a modest recurrence in curvature over time, and there's a relatively high rate of repeat surgery. When we looked at data over the entire United States, 20% of men who got this surgery ended up getting a repeat surgery within 1 year. Penile prosthesis, this is the surgery that's reserved for men who have erectile dysfunction issues as well as penile curvature. And the nice thing about this is it improves both, and it has a relatively high satisfaction rate overall. Downside here is, again, it's permanent. You can't get spontaneous erections anymore. And there's about a 1 to 3% chance that it gets infected. You have to have it taken out and replaced. But again, overall satisfaction is high here, and it has a very specific indication for those who have erectile dysfunction issues, as well as penile curvature. Well, are there any therapies that you should avoid? As of 2020, these therapies are probably the ones that you definitely want to steer clear of. The first is shockwave therapy. There is specifically an AUA, or American Urologic Association guideline, as well as a Sexual Medicine Society of North America position statement, which says that people should steer clear of this treatment unless you're going in some sort of research protocol if your goal is to improve curvature. In fact, I've had several cases where this can actually worsen the condition, so you definitely want to steer clear of that particular therapy. Stem cells and platelet-rich plasma are two other therapies that you generally want to avoid because, again, lack of data or lack of data showing improvement. Now, these treatments are not illegal, but they're very unethical at this point, and really the only benefit of them is you're going to enrich the clinician who's treating you with them. And again, like I mentioned earlier, in many cases it can actually worsen the condition. So in summary, your specific treatments will depend on what your goals of treatment are. If you want to be treated for hourglass deformity versus pain versus length improvements versus curvature, the therapies may need to be tailored a little bit. We usually recommend first-line therapies be those that are more conservative in nature, those with lesser side effects and those that may offer improvements, while we reserve second-line therapies for things that are going to be more permanent in nature, such as surgery. Well, thank you for joining me for this presentation on treatments of Peyronie's disease. If there are any other videos that you would like us to create, please don't hesitate to email us at email@mfp.clinic, and we'd be happy to do so. Thank you very much.